So I'm really pleased to welcome to the channel today Dr. Aslani, who is a plastic surgeon working from Marbella, Spain. He's the surgeon that I had my surgical BBL with about 6 months ago, which I'm super happy with. And he's really kindly agreed to come on the channel to talk a little bit about his experiences. And one of the questions that we get asked an awful lot is about the safety of this particular procedure. So maybe you'd like to take it away and tell us a bit about how your procedures are different.
Thanks for the introduction first. And secondly, I think you're raising an extremely important point, and the background of the point that you have basically comes in 2 steps. The first step was there was a publication which is very controversial, which was published in PRS a couple of years ago, which quoted a 1 in 3,000 mortality rate for fat grafting BBL. This publication is historic. You know, this is not valid data, but I'm coming to that in a second. For me, subjectively, you know, for my personal practice, we saw a certain escalation because we have a lot of patients coming from the UK when a couple of deaths occurred in Turkey. And then suddenly there was a lot of public attention regarding that point, but the problem is older than that. The problem is older than that. And the background is, look, guys who do that, and I've been doing this intensely for 10 plus years, we all injected in a kind of hooray style fat with syringes into the muscle by the beginning of the last decade. You know, we did this up, right, down, left, and center. And then a Mexican surgeon, his name is Cadenas, he published this first in 2014, and he said, guys, be careful, there's a nasty problem when you inject fat into the muscle, because what you can get is something that we call fat embolism. That means you have deep veins in the muscle, you go in with a syringe, you give a bolus injection, the fat bolus goes into the vein, goes into your right heart chamber, and that's a lethal incidence. This is something that of course, I mean, it's surgeries like that. We weren't aware of that before. We weren't aware of that. But he was the first guy who summarized, because he was at that time the president of the Mexican Society, and said, look, we have so many deaths here around BBL, we need to understand why. And this is a problem that I think then we understood, we analyzed, and we solved. I mean, not we. When I say we, the credit goes to I think probably one of the most charismatic surgeons of our decade. His name is Daniel Del Vecchio. He's from New York. I have the pleasure that he's a good friend of mine. He told me how to do this. He developed something that we call EVL. EVL stands for expansion, vibration, lipofilling. So he developed a system where you don't use syringes, no bolus injections. You use a blunt 4mm basket cannula. We've got total palpation control. And I'm relatively firm in my position. I consider that bulletproof against fat embolism. So with this technique, it's never happened. The problem was, you know, that of course, you know, is this became a boom surgery 3-4 years ago. And then suddenly, you know, people, and probably very talented surgeons, that said, cool, now we do this. They might be very gifted fat grafting surgeons, and they started doing the syringe thing they were used to just because they weren't aware of the problem. You know, if you don't go to the conferences, you might not know. So that was an accident waiting to happen. But with EVL fat grafting, we consider it, I personally consider it to be a very safe operation. I hope that answers your question.
Why don't you tell us a little bit about the technique? Am I right in thinking that you developed using the implants and the fat grafting?
Yes, let's say we came from this. What I was just commenting on was BBL fat grafting only. So to come to the semantics, for us, there's 2 different operations. BBL is commonly defined as fat grafting to the buttocks only. Hybrid, supercharged, or composite butt augmentation is referred to as implants plus fat. You know, that is always patient dependent. So what we did is I've always done a lot of butt implant surgery, and then Daniel Del Vecchio started showing me his EVL technique, and then we started to merge the 2 things together. And we said, look, we combine butt implants with EVL fat grafting. Well, that actually works pretty well. We actually got that published in last year's PRS, and that was a very well received article. And that kind of combines the best of both worlds. Yeah? So we try to add a safe fat grafting technique plus the implants, and I think then I think I wouldn't know how to cause a fat embolism even if I tried. So that's probably the safest thing you can do.
One of the questions that patients have been asked is, how do you know how big an implant to place?
Compare it to, I would say, imagine you want to put a burger into a bun. Yeah, the burger can impossibly be bigger than the bun. And the way it works, to answer your question technically, we dissect a pocket inside the muscle, and then we place a so-called tissue expander. Yeah, that's an inflatable implant, and we see how much volume we can place inside the muscle without stressing the tissues. And this is how we decide what implant size we use. It's an intraoperative decision making inside the surgery.
And do you ever change the implant then the second time that somebody does the BBL to give a larger implant?
We do this on selected occasions. To be honest, we try to avoid that. Yeah, that means it's because an implant and tissues are neighbors. They're not friends. We don't want a lot of silicone can cause a lot of tissue problems. So I think as long as the implant sits snugly inside the muscle, you will have very little problems. If you can theoretically, when the muscle is expanded, upgrade for a bigger implant. I would say the majority of my patients, I mean, they all want more, which is it's a, let's say, surgery patients enjoy, and they want a bit more of it. But in the majority of cases, we add additional fat grafting. That is less traumatic, works very well in the second rounds because the hips are widened already, and that usually is the best possible solution. You can upgrade the implants. Usually when we do this, we kind of introduce an additional soft tissue support, a so-called mesh, to support the muscle. But I would say it's not the first line option. 95% of patients come back for second rounds after supercharged combined BBL. They just do additional fat grafting.
And how much are you putting in each time?
Fat grafting or implants?
Fat grafting.
This is a good question, but it's not so easy to answer because the point we call that tissue saturation. Yeah, that means and this is the learning curve on fat grafting. That means you want to put as much fat as the tissue can kind of receive without undue pressure. The way that I like to compare that is imagine like your buttock is like a boat and the passengers is the fat. So how many passengers I can put depends on how big the boat is. And this is the explanation why fat grafting has a progressive effect. The first round is usually the hardest because you want to widen the hips, an area where the skin is very tight, and you're kind of running with your head against the wall. So you don't want to try to put 150 people on a boat where that's only got space for 30. However, the second time the boat is bigger, if it makes sense what I say. Yeah. So you decide. It's to answer your question. It's not gut feeling, but I would say I decide that by palpation. Yeah, this is something I think you really have to do it a couple of hundred times to get the perfect point. You feel the tissue is tight, but not rock hard, and then you stop. But it's not a mathematical thing.
Do you know what kind of percentage of the fat are you expecting to lose?
Again, sorry, I always give complicated answers, but it's a tricky question because you have to differentiate two things. The fat resorption is relatively constant in about, I'd say, 25 to 30%. But what people need to understand, and this is something that I'm always very adamant to educate patients about, there's a difference between fat loss and volume loss. What I'm trying to say with that, when I graft 1000 cc of fat, as it goes into the surgery notes, you can expect 20% of that to be water. Because we call that the fluid phase. Logically, if fat has got no water, it's butter. You cannot inject butter. That's impossible. So even with all purification, we always need to keep a certain percentage of water because otherwise we can't inject it. What I'm trying to say, in the end of the day, you lose that water plus you lose the fat. Make sense? So this is very important for me in patient education because they get all super excited the first day. And I say, look, take it easy, hold your horses, because that volume goes down a total of 50% approx. That is 20% water and 30% fat. It's not only fat.
And over what kind of period of time would you expect it to stabilize?
About 6 to 8 weeks. Bear in mind, that everybody is extremely different. We're not carpenters, working on wood. There's a soft tissue response which works in some better and some worse, always depending on the case. I'm giving you average volumes. Yeah, so this goes into stages, and this is why it's important to explain that to BBL patients. They get a very drastic volume loss in the first 10 days, which for us is for the psychology important, because they get like super excited the first day and they love it, and then it deflates and they panic because they think they're going to lose all the volume. But it's just the water goes down very quick, so at a lot of volume reduction in the first 10 days, and then progressively over 5 to 6 weeks you get the fat resorption.
And do you have a specific method of cleaning the fat that you use?
That has simplified over the years. Yeah. So currently, what we do, we work with a sterile collector. So we have both infiltration fluid and fat in the same canister, and it's not exposed to any air, which I think is a great thing, to reduce any risk of infectious complications, which are, thank God, not very frequent in the surgery. What we do is we submit the collected fat to a very short period of vacuum to mix it over, and then we let it decant. What we stopped doing over the years is centrifuging the fat, because we learned that this does more damage than good.
Interesting. And is it possible to do something like this on someone who's very slim?
You can't do fat grafting without fat. You can't squeeze blood from a stone, of course. Yeah, but I mean, what you refer to is something that my coordinators like to call slim BBL, which is cool. Yeah, but I'm always trying to be a bit cautious with these things. Yeah, please correct me if it doesn't make sense what I say. If people want a slim BBL, I always expect them to have, let's say, somewhat slim expectations too. Yeah, and that, in modern social media times has become a big challenge. I mean, this is. And I think this is progressing. Our possibilities are increasing at 100 miles an hour. Patient expectations are escalating by 300 miles an hour. So it's not unusual to have patients who are super thin and then say, look, I have reasonable expectations, but in the end of the day, you find out that they're expecting to have a kind of ghetto butt in one session. And that's very hard to please. You can get a lot of fat out of a thin patient too, but there are limits. There are patients where it is impossible.
This is kind of an aside, but are you doing fat transfer to the breast?
Yes. However, bear in mind, I think look, to give you an insight into this, it's a little bit the other way around than in buttocks. In the buttocks, fat grafting is solution number one. Yeah, so currently, to give you an example, I have a case that I do a little bit less than 1,000 buttocks a year. Yeah, usually we do these combined, and I would say probably 70% is fat grafting only, and 30% is buttock implants and fat grafting. In the breast, it's the other way around, because in the breast, implant is still solution number one. Yeah, that means the reason is we cannot graft fat directly into the breast. We have a very limited recipient tissue. So in a buttock, it's not unusual. We have grafting volumes in an average somewhere between 1,000 to sometimes 1,800 or 2,000 cc, depending on patient anatomy. That's very big volumes. In the breast, hardly ever more than 200-300 cc. So it's a nice supplement to implants. It's a very powerful solution in implant removal, but it's not a good, or it's not a very powerful option for primary breast augmentation.
This might not be up your street, but I understand that some surgeons are using this Brava before they're doing fat grafting to slim patients. Is that something that you use?
Are people still using that? I think it's a bit historical. The Brava thing that was kind of had a bloom in the beginning of the last decade. I'd say that was something that was published, and I think it's a great concept. It's a great guy. It was published by a guy from Miami, Roger Curry, and he was doing that to expand the scaffold. He had fantastic results with this. I think it's a good solution, but the thing is, I think patient acceptance is zero. Yeah, because nobody wants to run around with two vacuum bombs here for 60. They just do a second session in that case. So unfortunately, I think it is a good option, which had a bit of an unfortunate career because patients just didn't accept it. I mean, I got a kit of Bravas about 10 years ago, and I think we still have them. Nobody ever used them.
Wow.
Yeah, because you said to no, but I think this is not because it's a bad technique. It's a good technique, yeah. But it's just when you show to patients these things, which look like a medieval torture device, and then they say, "Gee, forget it. I just do 2 sessions, get lost." But technically, it's good. However, I'm actually currently not aware of that anybody is still using it.
One of my patients was just discussing with me about how she was going to have it done in the States. So maybe it's something that's still used over there. Perhaps.
It's possible. Again, let me emphasize, I think it's a fantastic, this guy, I mean, George Akuri is probably one of the most brilliant and innovative minds, yeah, and he's doing fantastic things with that. Yeah, and I think it's a bit unfortunate because it's a great thing, but it's just kind of fallen out of fashion because patients kind of refused it. But not because it's bad, just because it's inconvenient.
And just going back to the BBL, are you ever getting men in for this?
Excuse me?
Are you ever getting men in for the BBL?
We do, but not very frequent. Let's say there's guys, to give you an example, who are very male-orientated practices, like Doug Steinbreck in New York. I mean, he's the only man. I think he's probably never seen a woman in his theater for years. But I think even he says, I mean, personal correspondence, he says, men do implants, but BBL in men, I hope I don't say something he doesn't agree with, is not an extremely frequent thing. I think we may have, let's say, 1 case a month, one every 2 months. It happens, but not very frequent. Implants are a more popular option with men.
Okay. Could you maybe just talk a little bit more about your EVL?
Please let me stress, it's not my EVL, it's Daniel Vecchio's EVL. I'm always very adamant not to claim credit for something that I didn't invent. EVL is basically what it does. It uses, I'm not sure if I've got one of these cannulas here to show you. Luckily I have. Maybe, is it visible if I hold this into the camera?
Yes.
Look, this is a so-called basket cannula. Yeah, you see, this spreads out here, and this is connected to a so-called vibrating handpiece. So this thing starts to vibrate. Yeah, and the cage then moves like a helicopter rotor. It's a bit like a Häcksler, so it loosens the tissue up, hence expansion, vibration. And we connect this to a device which injects fat with a flow stream of surgeon preference dependent, I would say 100 to 400 cc. I usually work with 300 milliliters per minute. When surgeons have less experience, I recommend that they start with a bit less. Yeah, so I think with more it becomes difficult to control. And then, with this vibrating piece, the fat kind of flows through there and is kind of expelled into the tissues. The way that I want you to look at it is, imagine, I'm not sure if you know these movies from the Second World War when the parachuters go out of the plane. Yeah, they jump out to the sides and there's no resistance. This is why I think it works so extremely well, because what fat doesn't like is sheer force and pressure. So you want it to move freely. When you go through a syringe, and this is why I think the syringes actually are obsolete. You take a syringe and a thin cannula. That is when you go from a 6-lane motorway to 1 lane. Yeah, there is shear. There is stress for the tissue, and there's friction, and that damages the fat. And this is why I think, even not only from the safety aspect, but from the volume take, this is far superior. Yeah. The second thing is, with this cannula, because you see I bent it. They don't come like this by fabric. I kind of bend them. I want it to be that way because I can always angle my cannula against the skin. Yeah, that means at no material time, I just move it about an inch to and fro, and at no material time do I ever lose palpatory control of my cannula. So I always know where it is. The problem with the syringe is that you have the syringe and a thin cannula, and this will kind of bend. So there is a massive difference where you think you are injecting and where you are injecting. I did actually try that out in a cadaver lab with a very famous Miami BBL surgeon, and just for fun, on a cadaver, we tried, to inject with a syringe, and we both have a few thousand BBLs on our mileage, yeah? And we both involuntarily injected into the muscle when we opened the cadaver afterwards, and we thought we were in the subcutaneous tissue. This is why this is good, because you have palpation control, and this is why I strongly recommend don't ever do that in the butt with syringes, because you can run into deep waters.
That's interesting. Am I right in thinking that you use ultrasound when you're performing the procedure?
We do so-called ultrasound mapping. Yeah, ultrasound mapping means that and this is, I think, if you ask me, surgical ultrasound devices have developed faster than the mobile phones in the last years. Yeah, so what we have now, we have that on a little iPad. Yeah, and then my assistant does, it's like a nautical chart. He measures the thickness of the subcutaneous tissues. So I'm like, it's like I'm navigating a boat over a reef. So I know exactly how deep is the water under me. And then I can control in which layer I can allow myself how much excursion of the cannula. We find this is the best, most efficient way to use it. We've also tried to kind of monitor, put the ultrasound handpiece on top. We found that not advantageous, because it enormously prolongs operating time. Yeah, you always lose track of your cannula. So in the end of the day, I mean, if you do that, your BBL lasts 5 hours, then I don't really think it gives you a safety benefit. Yeah, as long, because you have palpation control. If you know how thick your tissue is, and you sometimes are surprised, even thin patients, they sometimes have a 3-4 centimeter subcutaneous tissue layer. Then you get big girls, where you think, geez, you have a lot of fat, and then you measure and it's only 2 centimeters. So I think this is a great way to efficiently add a technical benefit to that. But what we don't want to do is we don't want it to prolong operating time, because operating time is the biggest risk factor in all surgeries. You want to do whatever you can to get the best possible result, but you don't want to prolong it unnecessarily. You want waste times, for patients cooling out.
Could you just explain to the viewers why you don't want a long operating time?
I think it's probably the most underestimated risk factor for complications, because, the thing is, whenever I'm asked to speak at a conference or wherever, currently, there's still in the surgical community a massive hype around, probably justified, around fat embolism. When people come to our courses, it's 95% of the questions are centered on that. And I think it's a very legit question, and we always want to, we offer these trainings to make sure that this doesn't happen again. Yeah, because there's always sporadically, there's a new case, and then people are worried, and I think they're worried for the wrong reason, because if somebody really does that a couple of 1,000 times with appropriate technique, I submit to you, and I'm firm in my position, this is probably safer than an eyelid lift. But what people underestimate, I'm opening a relatively simple secret here. If you ask me what currently propelled my practice most in the last 10 years, was a very simple thing: hypothermia prevention, cooling. When you are under general anesthesia, your thermal regulation is kind of knocked out. So every hour you are under anesthesia, possibly your temperature can go down 1 degree. And that is massive, because hypothermia is probably the most damaging and underestimated risk factor in major surgeries, because it increases your thrombosis risk. It can triple to quadruple your painkiller consumption. It prolongs your recovery. It's the source of 90% of the problems. Yeah? And it's the cheapest, safest, and most efficient way to protect your patients. And this is something where we really, let's say, a little bit hysterical about even. So what I do, and as I say, I can't suck fat quicker than somebody else, because the pumps just go at 500 millimeters. But what you can do is be efficient. I think a good surgery is a bit like Kung Fu. You always do like the same movements. And what we do, to give you an example, every Thursday afternoon, my theater staff, who do the same procedure all the time. Yeah, we basically do only that. And then they train, one has to lie on the stretcher and the others turn her. Yeah, so you would be amazed how gentle people become once they get the feeling that somebody else is turning you and you are kind of out of control. And they get faster. Yeah, so the positional changes, we managed to cut that down from half an hour to about 1 minute. And this is how you save the time. This is how you make a BBL faster. Yeah, is when people say, I think average theater time is 3.5 to 4 hours. That doesn't mean that they suck 2 hours longer than me, but they just lose so much time by re-scrubbing the patient, redraping the patient, turning him, and this is what over the last years we have perfectionized. We scrub everybody circular all the way around. We put you on sterile sheets, so we just have to turn you around, and this is why we cut down the waste times.
Yeah, I remember that. It was kind of like having a weird spray tan.
Yeah. It's not the most pleasant experience, but trust me, it saves you probably an hour of surgery time.
Mm-hmm. Maybe now we could talk a little bit about the expected side effects and then the more unusual complications.
Yeah. Define side effects. What do you mean by that?
Well, swelling, numbness of the skin, oozing.
Yeah, I mean, I think this is probably a totally normal observation in any kind of invasive surgery. I mean, bear in mind, I'm always very adamant with my patient, this is high intensity surgery. This is not like pimple popping. Yeah? So everybody will be swollen. The swelling is usually going to be asymmetric, because if you break both of your arms, they're not going to swell the same as well. These are normal things. Now, it's generally BBL only is not naturally an extremely painful procedure, but implants can be. That's very patient dependent. Some have, some don't. I would say average people have a bit of a hard time the first week. After 2 weeks, people will still remember me in ways that I prefer not to be remembered. After 3 weeks, it kind of fogs out. Yeah, then you have got people who already, I mean, they always have certain movements that they perceive as uncomfortable. Usually the flank area is quite numb, but that should be okay. Yeah. I'd say complication-wise, if you ask me what is the most frequent cause for corrective surgery after this, probably fat migration. Fat migration means that fat from the central hip goes down. I would say we see that maybe in about 5% of the cases, which not all patients bother about. Yeah, so some even like that because it gives a more inverted heart shape. Some don't like it. I mean, but this is something where I usually say, look, if it happens, we can correct it. It's relatively straightforward. We just retransfer migrated fat up. Asymmetry is definition. Now, asymmetry, I would say, we recommend or agree with patients to have a 10% margin of tolerance, because there is no such thing as a symmetric breast or symmetric hands or symmetric face. But if we do volume measurements after, let's say, half a year, and we see a noticeable difference, then we usually offer a reduction on the bigger side. That is very rare. I would say we have that less than 2 in 100. However, the small print is many patients, 7 out of 10 do a so-called second round. So that kind of goes into that as well. But a second round is not a revisional surgery. That is a wanted surgery. They do this because they want it, not because they need it, because it's a bit addictive. Yeah.
That's true. I am coming back in 6 months' time.
Yeah, so, we are looking forward to that.
In terms of then the more unusual complications that you can have after this,
I would say what I say generally is for me surprisingly rare, but of course can happen, is skin infections. Is logically, when you come into surgery, when I started doing this 25 years ago, I thought every second case I will have a major infection, because the worst thing that you can imagine as a surgeon is moving a cannula horizontal in a nearly avascular space, such as the subcutaneous tissue, but it's very rare. What we have found very effective, to lower that even more, is we use the same antisepsis protocols as the orthopedic surgeons, because the orthopedic surgeons are probably the absolute influencers, the role models for that, because these guys are totally hysterical about their antisepsis. Because if you get an infection in a bone, in a hip implant with a bone, then you're done goodbye. So what they do is I mean, you know, for our work, it seems maybe a little bit exaggerated, but it works for us, you know. So we let patients do so-called Hibitane, Hibi-scrub antiseptic showers. I think 2 weeks before we do these nose swabs, you know, to really make sure we lower it as much as we can. And I think I would say skin infections we may see less than 1%.
Mm-hmm.
And usually they're relatively light. The thing that we always dread is so-called mycobacterium infections. Thank God this is a very rare incidence. We usually relate that to tap water or swimming pool water.
Mm-hmm.
These can be very tedious, you know, they're because they're extremely difficult to treat and very chronic, but they're exotic. In my practice, I've only had one case in a diabetic patient. Yeah. But usually it's, let's say, relatively easy to treat superficial bacteria, which you treat with antibiotics. An important thing is, you know, when you do very aggressive lipo in the flanks, I would say we thin the tissue down to about 1 centimeter, which is a little bit more than the record. Most surgeons on the road will tell you go down to an inch, a little bit more than a centimeter. If I do that, my patients will probably spit in my face, and everybody will explain. With 1 centimeter, what we are very aware of is skin damage, so-called lipoburns. That is usually a combo problem of course, very intensive lipo plus the compression garment. So it's very, very important that patients remove their compression garment for an hour every day.
Mm-hmm.
So the skin can breathe. I mean, you can still have a lipoburn, but it's much less likely.
Okay. Anything else? Like we talked earlier about seroma.
Oh, actually, that's a good point. Seroma, but what we're talking about, Sarah, were butt implants. Yeah, in butt implants, seroma is probably my enemy number one. Yeah, that when you work with implants inside the buttock muscle, seroma is probably the most relevant problem. In BBL, not so much. Yeah, where you usually see it over the sacral bone, you know, just like over your tailbone. And this is actually something that we manage to kind of manage very efficiently. What we do, we after finishing the lipo, because you have a space where the skin is directly over bone, we inject 10 cc of diluted polydocanol. This is what the dermatologists use for the varicose veins. And that is extremely cost efficient and very effective to prevent seroma. And then we put a triangular pad. You remember you had that pad over you. The patients hate the pad, yeah, but it's extremely efficient, because since that the problem, I wouldn't say it's literally disappeared. Before we did this, we had massive seroma problems in that area. Yeah, which you then have to drain with a syringe. Since we do the polydocanol plus the pillow problem, I mean, we still see that by maybe 1%, and usually not relevant. So the triangle is there for a good reason, although you probably hated it too. This is for everybody.
Didn't love it. What about seroma after the liposuction on the abdomen?
Not too frequent. Yeah, is I think where people sometimes get a bit confused. Yeah, I think actual seroma after lipo, I don't think that's very frequent. What they usually have is water retention. That's a different thing. Yeah, and what you also may have noticed is that the incisions, we don't close them watertight. Yeah, we just put one stitch, not because we are lazy, but well, maybe that too, but because the water can then drain out of the sides. Yeah, is what many people do. I sporadically do that too. I just leave them open. You know, if I do a redo lipo and I have to inject a lot of water, sometimes I don't suture them so everything can drain out. What happens if you try to close it nicely, the water can't escape, and then they get a water kind of a fluid bag. But that's not a seroma. That's tumescent fluid that was left behind. And sometimes you have, you know, quick healer is not always good. We sometimes have that problem too. We put our stitch, 3 days later, everything is closed and they still have fluid inside. Then we have to drain it.
Okay. Does that not resorb on its own? You have to take it away?
It does, but it depends on the amount. Yeah, that means if it's, I would say this is a bit gut feeling. Yeah, is sometimes I feel there's a bit. We do an ultrasound, it's about 30 cc that will resorb. But if you have 200 cc, that might not resorb. And then you get a secondary seroma. So there's a cavity, a kind of capsule forms around it, and then you have a chronic problem. So case dependent, yes, smaller amounts we leave to resorb. We're very defensive with draining these things. But bigger amounts, yeah, we'll have to try.
What about speaking about implant infection specifically?
This is, I think, I'm trying to defend a good operation here. We had this discussion before. Look, there's a very specific thing about buttock implants, because I think nearly the totality of surgeons visiting us, and I think this is a bit of, I call that prejudice. They come with the impression that buttock implants get infected very easily, and this is simply fake news. This is not true. What happens in buttock implants is, and I would say we probably see this in about 1 in 20, 1 in 30 patients. We call that a delayed seroma. Delayed seroma means, I tell you a short example story. Patients, let's say after 3 weeks after the surgery, they have clear yellowish fluid draining from the incisions. And this is something that somebody, often, we have visiting surgeons who are very seasoned breast surgeons. They have done 5,000 breasts, but in a breast, when it drains fluid, it's over. Then you have to remove the implant. There's no chance. There's no chance. In the buttock implant, it means nothing. Because if it drains, usually no action is best action. You just do nothing. Because it usually ceases by itself. I would say 99% of delayed seroma stop by themselves. So that is sometimes a bit tragic. We had this discussion before, because we get a lot of secondary cases. People have been, I don't know where, and they say, look, I had an infection, they removed the implants. And if I dig into this story, I find out that with due respect, maybe an unexperienced surgeon has just thrown his nerves overboard and removed it for a seroma, whilst if he had just kept calm and observed it, it would have solved itself out. So that's a major difference between butt implants and breast implants.
Yeah, yeah. I mean, obviously, I had that complication, but these things happen with surgery sometimes. The path of surgery never runs smooth. I don't think I've ever had an operation that's been.
No. Look, I think this is always something that I'm always, I insist on very much. Yeah. So, example, I mean, you're a medical professional. I think if you go to a medical conference, to a professional audience, and you say, I do 1,000 cases and I have a complication, they kick you out. Yeah. They say, sorry, I mean, you're wasting our time, get lost. Yeah. So what you want to do is you want to have the lowest possible percentage. Yeah, and so you want to have the ambition to draw the percentage down as much as possible, but the wisdom to understand you never go to zero. Then you have to sell cars or insurances.
It's serious stuff. This stuff, it's a big procedure.
It is, absolutely. Yeah, but this is, and this is, it's the awareness, and I'm trying to be self-critical. That for us is always a bit difficult, because it's our daily bread and butter. We're used to that. Yeah, so. But I'm empathic with what you say, because 95% of my patients come from outside of Spain, and as I say, they don't come because we're such beautiful people, but they come because we have targeted experience, and I admire that. Yeah, but this is always the daily challenge we have. Keep awareness that it's a major procedure. I mean, but I also think it's got a major result. Yeah, so at least that is what patients tell me. They say, look, it's what you guys are nuts. Yeah, but Jesus, when I see myself in the black dress and in the high heels in the mirror afterwards, this is second to none. I never get this kind of feedback with breasts and noses. But having said that, it's also, and I'm making it clear, it's got a huge obsession potential. I mean, most problems that I perceive for me are psychological. Patients go crazy with that.
I think you told me that some people do it 4 times.
Oh yes, man, more 4 times. Look, the thing is, let me break it up this way. I would say, of my original patients, I would say 60% do it twice, or 70, depends. But again, because they want, not because they need. I would say 25% do it once, 5% do it 3 or more times. But I'm always counting my BBLs. Often people come, no disrespect intended, with what I call homeopathic BBLs. So when somebody's injected like 200 cc, that's not a BBL. Yeah, that doesn't count. That's zero. You are right. You get many patients who are, they are very, I have people come in here and they say, look, I want to do round 2, 6 months later, round 2, round 3. You have these two. That is true. But what I always try to keep awareness of, is most patients bring me what we call these infamous wish pictures. I have a bit of a shifty relation to these wish pictures, because what I can tell you, most of the cases they show me, I know. Most of them I've operated, and they've all got 2-3 surgeries. Yeah. So, and this is sometimes a bit challenging, because I say, look, but yes, I understand where you're coming from, but but I want this in one. I said, well, look, it's what we want and what we can. Yeah, and that in the social media gets more and more challenging. Yeah, you can't get a great result for everybody, but you can turn everybody from Dame Edna to Kim Kardashian in one surgery. That's not possible.
Okay. Sorry, I forgot to ask you what type of the brand of implants you use.
I use currently 2 types, Polytech and Sabin. And I'm not very religious about better, but I'm interested in the measurements. I'm not interested in the brand. Yeah, so with the brand, and probably I'll get a shitstorm from the implant providers now. I think the differences at the established brands is very little. It's like if I ask your husband, do you like a BMW or Mercedes? It depends on who you ask. But it's all, let's say, good quality products. The specific problem in buttock implants is, since they're much less common than breast implants, I've got less choice of implants. And that's a problem for me, because the breast implant catalog from Polytech is like the New York telephone book. I can choose between like 3,000 different profiles and sizes. Butt implants, it's about one leaflet. Yeah, and the gaps are very wide. Yeah, so to give you, the most people will have implants somewhere between 270 to, let's say, a maximum 400 cc, and Sabin, for example, one is 270, the next one is 330. Polytech is 300, the next one is 390. So this is what if it makes sense what I say, it depends on what size I need. I'm not religious about a brand.
Okay. Is that anything that I haven't covered that you think would be relevant for the audience to know?
I think, what for me the most relevant thing is, I understand, all these medical concerns, and I think they're important, and I think we have to cover all these things. But for me, in my everyday life, the challenge is a different one. The challenge is something that's not my terminology. A very popular, actually, psychologist in the US has published it. He calls that Snapchat dysmorphia. Yeah, that people understand that we live in 220, and a photo is not a photo anymore. Yeah, so for example, my little daughter takes pictures of me. I swear to God, I look like if I was 200 years old. Yeah, my wife takes a proper photo. Well, I still look like I'm old, but I don't look like 200 years. Do you see what I'm trying to get to? Yeah, that is positive people will take positive pictures. Negative people will take negative pictures. That is more relevant for our practice, because all our people are out of town. So what I need people to understand is our work is producing a reproducible change in body proportions visible in neutral lighted, standard angle pictures. As you know, the lighting is important.
Yeah, you mentioned that to me just before the call. Yeah, that's super helpful. Okay. Well, I feel like I've taken up an awful lot of your time.
No, that was a pleasure. We're thankful for these opportunities. Yeah.
So thank you so much for agreeing to come on the channel. And I look forward to seeing you in 6 months' time.
So do I, Sarah. It was my pleasure.